Dr. Surendran, Dr. Jyoti Biswas, Dr. Natarajan, Dr. Mohan Rajan, friends of the Shankar Nethralaya alumni, and among them many close friends of mine. And the first picture that Surendran showed of Manju and me together brought back a lot of memories of over 35 years. This remarkable institution is an amazing creation. An amazing creation of a visionary and a legend. And through his influence, this large group of Shankar Nethralaya alumni contributed significantly to transform eye care, not only in India, but in many parts of the world. Because as the popular adage goes, education fosters excellence. And that's what this organization and the institution has instilled into the generations of ophthalmologists that went through the portals of this great organization. That education has raised the bar of eye care throughout India. In our own institute in Hyderabad and other parts of our network, we have a number of Shankar Nethralaya alumni contributing to our own work and growth. And about 6 months ago, we have identified 6 colleagues shortlisted, as one of them will be taking over from me towards late 2020. And 2 of the 6 happen to be the LVPEI alumni. I mean Shankar Nethralaya alumni. We could all wish them success in that endeavor. For all you know, one of them might be sitting in my chair in late 2020. We often talk about and hear about quality healthcare. What does it really mean? How many people who use that word really understand it, really practice it, really mean it? And the bigger question is, can we provide such care to every human being? Just a couple of months ago, we kept reading about the tragic events in Bihar of needless deaths of 162 children from acute encephalitis syndrome. A tragedy completely avoidable with minimal care. A tragedy that clearly shows that we don't have belief in quality. It's a result of many factors: illiteracy, malnutrition, and above all, a completely dysfunctional healthcare system. Juxtaposed to that is the wonderful story from Sri Lanka just a few weeks ago, where the WHO has declared that this country succeeded in eliminating measles completely. We are supposed to be a superpower, and Sri Lanka is supposed to be a tiny country next to us, with all its problems of years of internal strife. It has been able to overcome many of the primary health care problems that confront every country in the world. And I believe the reason for that is this sentence I picked up from one of the magazines and so appealing to me. What we suffer from in our country at the upper levels and at every level is poverty of ambition. If you look at those factors that I have listed that contributed to encephalitis, for each of them we have vertical governmental programs that are supposed to be taken care of. We spend thousands of crores of rupees each year, but yet we are not making a dent. The reason? There is no big ambition. And there is no big ambition in making things happen. And that's what is scary. Today we are at the point of confluence of diseases of the past and diseases of the present and future in our country, where we are number one in a number of diseases. And I don't see any big vision, either in Delhi or in any state capital of the country. Without that vision, how are we going to forestall the disaster of this confluence of healthcare problems? This quote from economist last year is so telling. So long as half the world goes without essential treatment, the fruits of centuries of medical science will be wasted. Only universal basic health care can help realize its promise. By many measures, the world has never been in better health. Yet, the gap between progress and the still greater potential that the medicine offers has perhaps never been wider. At least half the world is without access to what WHO deems as essential. Safe basic surgery is out of reach for 5 billion of the 7 billion people in the world. In studies of consultations in rural Indian and Chinese populations clinics, just 12 to 26% of the patients receive a correct diagnosis. So from that background, we have begun to aspire for universal health coverage, a committee constituted by Prime Minister Manmohan Singh several years ago, chaired by Srinath Reddy, President of the Public Health Foundation of India. They came up with a wonderful document, a document that aspires for universal health coverage, that ensures equitable access for every Indian citizen to affordable, accountable, and appropriate health services. That is comprehensive. By that I mean preventive, curative, and rehabilitative. So this is to fundamentally address the care for all neglected populations in our country and in the world. If we talk of universal health coverage, the focus should be on these neglected populations. And all these groups come under the neglected groups today. When we apply the parameter of the so-called poverty line, in 2012, it was supposed to be 22%. But however, McKinsey Global Institute came up with a completely different index, saying that poverty does not really denote abject poverty. So they wanted to create a new index, which is a composite of these 8 basic services that are essential for living. And when you have this composite index called empowerment line, and when you apply this to the Indian population of 2012, in fact, 56% of Indians are below the empowerment line. So this is the same population today that perhaps goes hungry every day. It's the same population which has no access to any semblance of health care. And this is compounded by yet another article about a year ago from Economist, cover page saying India's missing middle class. While we make a lot of claims, this is the reality. Only 1% of us really make $20,000 and above each year. So all of us sitting in this room are privileged that we belong to that 1%. Quite often we don't have that perspective. And look at the bottom half, equal to destitute parts of Africa. So that is the reality. So in that context, how do we think of universal eye health? Universal eye health, in our model that we tried to experiment at LVPEI over the past quarter century, encompasses provision of comprehensive eye care with commitment to quality, taking it closer to the doorstep of the people who need it most, with a continuity of care, with permanent presence into the communities, with active community participation. So out of that experiment evolved this model, the pyramidal model of 5 tiers. At the very bottom is the community-based primary care, where a vision guardian, what we call, keeps an eye on the eye health of 5,000 people. 10 such people then work with the next level, primary care, center-based primary care, through our vision centers, where a 1-year trained vision technician provides primary care. These kids are local community people trained and put back in their own communities to provide primary care. 10 such are then linked to a secondary level center where there are ophthalmologists and a team of 25-30 people, and then on to tertiary care. And each level, the care is appropriate to that level, affordable, accessible, and available. At the primary level, 100% of the care is free. At the secondary level, nearly 65% of all surgeries that we did till date have been provided free of cost. And at the tertiary level, it's about 50%. I'm sorry about this slide. This should have been 100 corneal transplants. What has it got to do with this? The reason is about 3 months ago, this was a story that emanated from our institute, that we completed 100 corneal transplants in our rural secondary centers. Centers where tertiary care was not meant to be given, not meant to be provided. This is the kind of communities to which this service was given. In 4 of our secondary centers spread over 3 states of Andhra Pradesh, Telangana, and Orissa, we have begun to offer tertiary care services. The idea is to take as much care as possible to those poor rural communities of high quality. And here is an example of one of our secondary centers in Bhadradri, former Khammam district, very tribal area, very poor communities. This is a gift from a local industry, the secondary center. That's where we have begun to offer most of the tertiary care services now. More recently, we have introduced complete retinal surgery equipment also and started offering those services too. This is a map of our network. We now are over 205 centers, 186 primary, 19 secondary, 3 tertiary plus the one in Hyderabad. So how did we do this in that kind of an environment, corneal transplant? We often talk of technology, often talk of machine learning, often talk of artificial intelligence. Quite often I'm so bored with that language, I get a headache. Everybody comes and talks about these things now. And I get about 20 emails every day from different companies offering artificial intelligence and machine learning tools. Is that the real solution? And I believe ultimately for the delivery of quality healthcare, it has to be a combination. A combination of appropriately trained talent and appropriate utilization of technology. And that's what made this happen possible, corneal grafting in a rural setting. We all know none of us who are trained as subspecialists in cornea, retina, glaucoma, whatever, would be willing to go and work in a rural area. But how do we provide those services? That has been a challenge that we confronted for a long time. And I think more recently, this has become possible because of, in some sense, going through an innovation in operations, an operations research kind of a question. What we did is we have been privileged to have a very active eye bank. So the corneal tissue is provided by that central eye bank in Hyderabad. We have the necessary infrastructure even in the secondary center because we don't want to compromise on quality, whatever we do there. And one of our corneal faculty travels to these centers every month to perform transplant surgery. And now we also have some faculty posted for a few months in the rural centers among the subspecialists. They perform the surgery, and our comprehensive ophthalmologist working there is fully trained to take care of the follow-up care of these transplant patients. In addition, we have teleophthalmology link, WhatsApp connection, and also a weekly grand rounds through a technology platform called Eco Platform, where all the secondary center doctors are constantly educated by our faculty at the tertiary level. You all know very well, for the success of corneal transplantation, 3 essential prerequisites: the quality of the donor cornea, nature of recipient pathology, and of course the issues like the training of the surgeon, the infrastructure, and most importantly, the post-operative care. This all has become possible because at the base of all this, right in the beginning, 32 years ago, we have focused on creating a comprehensive cornea center. A center that would encompass everything that is related to high quality cornea work. And out of that, and this has become possible. When we thought of an eye banking in 1987, when we started the institute, everybody told me, forget it, just concentrate on cataracts. There were 2 myths at that time. Corneal transplants don't work in Indian eyes. Nobody in India donates corneas. And the same message was conveyed to our American friends when I sought their support. Nobody was willing to help. Until Virendra Nirankari in Baltimore, a close friend, a corneal surgeon, convinced the president of the then president of Tissue Banks International, Frederick Griffith, to help us. That helped us to create the eye bank. And when we completed our 25 years in year 2012, by then we could complete 20,000 transplants in our institute. That became possible because of a variety of factors in eye banking. The most important being the starting of the hospital cornea retrieval program in one of the major hospitals in Hyderabad, in addition to other things which are slow-moving kind of initiatives. And this has been the growth. This past year, we have completed over 10,000 corneas in a single year in our network, harvesting, of which we supplied corneas for 6,000 plus transplants across the country. And in our own network, we performed over 3,000 transplants. All this is just one example of how each subspecialty can evolve with a strong base, appropriate innovative operations research as and when time demands that and requirements demand that, and then move forward with it. This has become possible for a variety of factors. The first thing is commitment of the management to make these happen. Technical partnerships with people who have the necessary expertise, resource mobilization, partnerships with hospitals, excellent quality human resources, infrastructure, systems, and overall an enabling environment. So these were all the various steps that made all this happen. But the problem why we had to go to rural areas is if we did on a few of them at the tertiary centers, more than 40% did not return for follow-up. And that has necessitated these initiatives. Service in rural secondary centers, we are now working with 13 medical schools in these 3 states to enhance their capacity in corneal services. We are linking actively with many residency programs, and we're also now involved in creating eye banking in the north and northeastern part of India through a grant from an international agency. And of course, the MR, drone, slit lamp, and echo have made it even easier. But all this cannot happen in isolation. This happened because this whole thing is part of an integrated model of eye care delivery. Again, going through the same 5 C's that I have alluded to already at the beginning. It fitted so well with the subsequent publication from the World Health Organization, the annual World Health Report, where they defined primary care as having these components. It has to be a person-centered care, a comprehensive and integrated response, very important continuity of care in those communities. You have to be a regular and trusted provider at the entry point. You have to take responsibility for a defined population, and you have to have coordination of inputs from other levels of care. So it has to be an integrated system. So we've been going through these innovations in different parts throughout our 32-year-old journey. In service delivery, the first one was the creation of this integrated model. And of this, the bottom 3 tiers we call village vision complex, integrated secondary and primary care centers. And I think that's where we make the most difference. I quite often tell my colleagues in Hyderabad, if we are not there in Hyderabad, somebody else would have been there. But in these rural areas, if we didn't go, nobody would have gone. That's where we are making the real difference. Not in Hyderabad, not in Vizag, not in Nageshwar, not in Gullapalli. This is where our institute should go and make a difference. And this is what is possible. The bottom 3 layers can take care of 90% of the major problems of blindness and vision impairment in our country. And that's where we should all concentrate. So we also talk about comprehensive care without not really understanding what it meant. It has to have all these 3 components. The first component is barely touched in our country. We are very good in mission mode prevention programs like polio, but the sustainable long-term programs like even vaccination, we fail miserably. Otherwise, there is no justification that we have only 55% vaccination rate in our country. Treatment, episodic, a few islands of excellence in the country, but the average basic standard is still a long way to go. And then rehabilitation, we should not even talk about it. We don't do anything at all in the real sense of rehabilitation of people with irreversible blindness, low vision, and in other disabilities to speak of. In iBanking, we proposed a 3-tier model about 27 years ago. That's being replicated in some parts of the country, and that has paid rich dividends. In innovation, we started with focusing on the need and then develop appropriate competencies to meet the need, a 3-tier fellowship, optometry fellowships, and more importantly, I think this is where we really help kids from disadvantaged families, particularly in the rural areas, those who just completed 10th class, those who completed 12th class, and build careers for them while they turn out into top-class nurses and technicians with the proper education. And in innovation in biology, one classic example is most of you are aware of is in the area of stem cell biology, the simple limbal epithelial transplantation that can be practiced by any practicing ophthalmologist anywhere in the world without the need for a complex stem cell biology laboratory. And in technology, at the screening level, our group has come up with this folding phoropter. Within 1 minute, you can screen a kid plus or minus 0.5 accuracy. So thousands of kids, our dream is to place this in the hands of every school teacher in our country. At the next level in the vision centers, we are using the attachments to slit lamp and then appropriate apps to be able to use teleophthalmology. At the secondary level, we are using Jean-Marie Perel from Bascom Palmer, his technology of drone slit lamps, where the patient is sitting in the secondary center and the expert in tertiary center can actually examine live and then give an opinion. And we're also looking at some other tools in the Technology Innovation Center to assess the responses of the pupil, etc., the pupil plus, and then more recently, one of your own optometry alumni, Prem Nandini, innovated and developed this pediatric perimeter, which doesn't exist at this point. And more recently, one of the brilliant engineers that we've been working with, a young lady, developed this order of magnitude, the thing that can replace typical expensive field machines with a simple experiment where the patients can buy and do their own fields at home and send the reports to us. So these are all the things that are happening. And we talk of big data. More recently, we began to really mine our EMR data. And one of the papers, two papers came out actually. One is the Javed Ali, who is a prolific writer, who started the concept of Institute of Bacteriology, and he publishes 30 papers a year. That guy went through his own records and published this large data paper on lacrimal system. And a couple of months ago, this paper appeared on the dry eye, again going through the EMR data. So we have rich Sankar Netralaya has a fantastic EMR system. So these are all the systems that can be very educational to us and help us in the future planning and education system. So from all this, through that 5-tier structure, and these are the 10 functional elements of LVP today. It is the coordination and intermingling of all these 10 functional elements that make all the things happen in our institute. I deliberately used the endothelial matrix pattern here because just as the interdigitation there is so important to keep the corneal clarity, to keep the survival of LVP, the interlinking and close functioning of these 10 functional arms is so very important. And each of these played a very important role in our day-to-day functioning. So, ladies and gentlemen, it's the combination of health systems innovation, high quality human resource development, appropriate and relevant research and innovation can lead to a world in which nobody is needlessly blind, and also those with unavoidable vision loss can achieve their full potential. I felt very happy crossing Brahmaputra about 1.5 years ago from Jorhat, going to the biggest river island in the world called Majuli. When I saw the inauguration of a vision center there, I felt very happy. Because the only way you can get to that island is by boat. There's no road connectivity. So we have arrived, I thought, when I saw the vision center there. And that community of 100,000 people. Can you play the video? It's a nice video. Some of you may have seen it. I got the same feeling a few years ago going with Rubens Belfort. He is doing some work in Amazon Islands. So going on Amazon gave the same feeling as going on Brahmaputra. And that's a fantastic feeling. This is the picture of Majuli Island in the middle of river Brahmaputra. So ultimately, this group of Shankar Netrala alumni who have contributed so much to transform eye care still can do a lot more through you and through the generations of people that you influence and you train. Because education is transformation. It's a privilege and at the same time confers a huge obligation on us. And I'll show you one more moving video clip. This I'm showing everywhere. Some of you may have seen earlier. I've been showing this for the past 2 years everywhere. This is a situation that we should all try to prevent. What you see in this picture, in this video clip. Every day, many sons must be undertaking such perilous journey for the sake of their parents. So how do we eliminate that need in future? And I end with this quote from J.K. Rowling when she spoke at the Harvard graduation ceremony about 10 years ago. And very, very powerful. Your intelligence, your capacity for hard work, the education you have earned and received give you unique status and unique responsibilities. That's your privilege and your burden. If you choose to identify not only with the powerful, but with the powerless, if you retain the ability to imagine yourself into the lives of those who do not have your advantages, then it will not only be your proud families who celebrate your existence, but thousands and millions of people whose reality you have helped change. So ladies and gentlemen, this group of Shankar Netralaya has the immense ability to convert the poverty of ambition into power of ambition. And if you have feature that power of ambition, and this will become a reality, universal eye health within reach. Thank you so much.
Friends, I should confess that it was very, truly inspirational and motivating to hear Dr. G. S. Rao. Let's give another big round of applause. It is wonderful to learn your speech. Good job. We are very fortunate to have a person of a caliber to deliver the prestigious SN Alumni Oration today. Thank you very much for this wonderful opportunity and your presence as well.
Thank you once again.